the most effective way to deliver the oxygen in these patients is by mechanical ventilation. So start with establishing an airway first. So this is your first priority. Once established that your patient is unable to meet their own oxygenation needs via spontaneous breaths, so we will go ahead with intubation and hooking them up to a ventilator. Although it's not the nurse's job to intubate, we have respiratory therapists, physicians, nurse practitioners, or nurse anesthetists who can do the job. The nurses are the ones initiating it though. So you're the one at the bedside assessing the patient, and then you decide that the patient is no longer able to sustain oxygenation on their own, so therefore you call rapid response. The other instances wherein we intubate is in the OR, of course, when we have patients that need general anesthesia because they're also paralyzed, so therefore they will also be intubated. The endotracheal tube is the most convenient and the preferred route. The nasotracheal means it will be smaller tube. It's only done in, let's say, smaller children, babies usually, or if there's any contraindication that we can't do it, let's say oral trauma, for instance, or throat trauma, wherein it makes it difficult to do oral intubation. Intubation is now peaceful, it's quick, we can get it done from start to finish in under 90 seconds. The procedure, evidence-based procedure, is now rapid sequence intubation, which is you sedate the patient first. Usually we use rocuronium that will calm the patient down. Of course, they're out, so now they can't fight, because even if your patient is so weak from the respiratory distress, if they're still awake, they will fight and resist oral intubation. They're already hypoxemic, confused, restless to begin with, and then here's somebody putting in a stainless laryngoscope into their throat. Of course, they will fight. So to make it, no trauma, no injury to the teeth, the mouth, the lip, or the throat. So we sedate the patient real quick. In a few seconds, they're out. We put in the laryngoscope and then the airway after that, and then voila, we're done. These are your other indications. As already mentioned, we also do it for general anesthesia. Our job begins, besides initiating the intubation, our job begins with right after the airway is put in. So we will need to first of all is we need to verify placement of the tube. Is it in the right place? Then we need to seal the trachea. That way we don't have any leaks, so that will ensure proper oxygenation. And then we will need to maintain a patent airway, because the airway is a foreign object. It's a hard plastic tube. It will therefore stimulate constant mucus production as well as salivation as long as it's in place. So you need to maintain the patency by removing secretions that could block the lumen. Then finally, you need to secure that tube, make sure it doesn't move, it stays in place. During the procedure, whether even if the patient is already out, or they're still confused, hypoxemic, we still, just like with anything else, we still explain the procedure either to the patient or the family, whichever is applicable. Even if the patient doesn't comprehend, we still explain the procedure. Um, Suction equipment is already available at the bedside. Since this is done either in the ER, the bedside, or in the OR, there's suction equipment available anyway. So like I said, it's pretty quick. If, however, you're unable to intubate within the first 30 seconds, we take a break, let someone else do it. Because other than that, if we're unable to put in the tube, then that means no, it's delayed, and we need to try something else. Let's look at the parts of the tube. So this is a typical endotracheal tube. We have markings on the tube right here, 18, 20, 22. These are centimeters. We need these markings to see where it exits out of the teeth. If the patient has no teeth, then we will use the lip. These are documented on the chart so that we know how far the tube is into the airway. It needs to sit 2 centimeters above the carina. The carina is the spot where you have the main stem bronchus branching to become the right and the left main stem bronchi. The um, the analogy would be if it was a person, the right and left bronchi would be your right and left leg. So that means the carina would be the equivalent of your crotch. Okay, so the tip of the tube must sit 2 centimeters above that. The purpose is, since we calculated the tidal volume is the amount of air delivered by the ventilator for each breath. It's already calculated for both lungs. So in the event that the endotracheal tube is pushed too far down, it usually goes into the right bronchus because of the anatomy and the anatomical shape of the right bronchus, which is straighter, unlike the left bronchus, which is more angled. It's more of an acute angle. So it's impossible for a rigid plastic airway to um, to go to the left fork, right? So usually it goes to the right fork because the right fork, the right bronchus is straighter compared to the left. So these markings therefore establish where it stops. So once we confirm, we'll explain later how to confirm placement. So this is one lumen. The second lumen is for the cuff. This is the cuff, needs to be inflated to secure the tube as well as to block secretions from coming down from the throat and into the lungs. There is a convenient endotracheal tube which has a third lumen branching out here. So let's say this is your trachea. So that means this is the patient's um, neck. Okay, this patient's neck. That's their jaw. That's their head. And this is the esophagus right here, behind it. This area here will also collect secretions. Because of the presence of the tube, of course, the patient cannot swallow. Therefore, they cannot protect their airway. So we need to seal this area here. That way, no air leak goes, no air leak occurs, and no secretions come down to aspirate the patient. So as soon as the ET tube is inserted, the person inserting it will confirm, um, well, we need to seal it first. So once in, we start bagging the patient. The tip of the ET tube, the end of the ET tube, exiting the mouth will be connected to a bag valve mask, and we start giving the patient breaths manually. Meanwhile, somebody puts a stethoscope here and then listens as the air is being pushed in manually. So of course, if the ET tube cuff is still deflated, then that means there will be air leaking around the side. So as air is pushed in, remember there's resistance in the lungs. So if you're doing it manually with this thing deflated, air will have difficulty going into the lung. So most likely air will be leaking out to the side, going back out through the mouth. So you will of course hear a lot of air movement, a lot of leaking sounds. You slowly inflate it. I forgot to okay, let's go back to the other screen. So up here, this is called the pilot balloon. If the balloon is deflated, that means the cuff here, the cuff is also deflated. If the pilot balloon is inflated, meaning it's bulging because there's air in it, that means there's also air in the cuff. This is also inflated. However, since this is tiny, there's no equivalent. We don't know how much air is in the cuff. We just know that it's inflated. How much pressure is there, we have no idea. So this is where we attach a syringe to the end of the pilot balloon. This is a one-way valve, just like your IV clay port, IV port, wherein you push the syringe, it opens. So same thing, we push that, we connect the syringe, and then as we are inflating it, so as we are inflating the cuff, of course the leak will go fainter and fainter until it disappears. So that means you have now achieved minimal occluding volume. We need only minimum, because if we overinflate the cuff, that means it will now put pressure against the vessels on the trachea. We don't want that happening, because of course ischemia will lead eventually to necrosis. This tube will be in here for a while, so the whole time you are overinflating the cuff, that is causing harm to the tracheal tissues, and therefore again it will lead to necrosis. So as soon as you meet minimal occluding volume, meaning you don't hear any leaks anymore, then you stop. After that, we will attach a manometer. A manometer is a pressure measuring device, pretty much the same as the tire pressure gauge indicators that you have at home. So you attach it to you remove the syringe, you attach the manometer to the pilot balloon, and then you press the trigger, and it will tell you how much pressure is in the cuff. To describe a manometer, it's the same size of a handheld scanner at the checkout counter in the grocery store. You know how when you have a barcode that wouldn't scan on the flat um, surface where you have your scanner, then you pick up this handheld scanner. Do you know what I'm talking about?
Yes.
Yeah, so it's the
Yes.
same size of that as that handheld scanner, but of course, instead of having a laser on the head, you'll have a gauge, similar to the um, what you see the gauge on the sphygmomanometer when you take somebody's blood pressure manually. So it's the same manometer. So it measures pressure. So when you press the trigger, it will tell you how much pressure is in the cuff. The pressure should only be between 20 to 30. I'm trying to look for it. Okay, here. So the endotracheal cuff should only be between 20 to 25 millimeters of mercury. That's equivalent to about, um, I think, 20 to 30 centimeters of water, um, more or less. So if as long as it's between 20 and 25 millimeters of mercury, then that is safe. Why a range? We don't know what your tracheal diameter is. We have different sizes, we have different heights, so therefore the tracheal diameter will differ from person to person. But the normal range is it should only be able to accommodate between 20 and 25 millimeters of air. If it's too high, as explained here, I already mentioned, it will cause necrosis to the trachea and possibly bleeding. Low pressures, on the other hand, that means your cuff is underinflated, then that will cause air to leak around, and therefore you don't have effective ventilations because you have a lot of air leaking out. So most of the tidal volume you are delivering is not going into the lung but going back out into the mouth. Plus, the more dangerous consequence is you'll have aspiration of secretions. So secretions will go around the leak because you underinflated the cuff, causing pneumonia. So we do that initially, pending, because we need to ventilate the patient until we get confirmation of the placement of the tube. We need to continue um, ventilating the patient. And again, we cannot ventilate effectively if there is a leak. So that is what we do first, and then somebody gets a X-ray. The X-ray tech is there at the bedside as well, taking a with a portable X-ray machine. They'll take an X-ray, and then while they're there, we will have to confirm placement another way. Since there are two tubes there that your tube could possibly enter, it can go either into the trachea or the esophagus. To quickly confirm that you are not in the esophagus, we will use an end-tidal CO2 detector. This is called a manometer. There are portable ones, smaller ones the size of a pulse ox. Some of you may have bought pulse ox when COVID-19 started because they were made available at good prices in pharmacies. But we do have bigger ones which resemble a blood pressure machine. I don't know if you've noticed them in clinical. We have one on the floor. They probably keep it hidden because people mistake it for a blood pressure machine. Anyway, so you put the sensor at the tip of the endotracheal tube. You put the sensor, you attach it here, and of course it's
Wait,
a
I don't hear.
capnometer.
Professor,
Yes.
we're not seeing the screen.
Yeah,
But you
I
have
thought
your
it was
textbook.
only me.
Okay, you're looking at your textbook too, right?
Thank you.
Yes, I didn't know which spot you were
Yeah,
looking at.
it's
Okay.
chapter 7.
All right, so you attach the capnometer here, the sensor, and of course it will detect the presence of CO2. If the CO2 is detected and the levels are either normal or high, that means it's in the trachea. There is very little, if any, CO2 in the stomach. So that will tell us, oh, it's in the stomach. Of course, if there's none, then the tube is in the esophagus. Other ways, because it will take about 10 minutes for us to get the x-ray result. So while waiting, somebody's bagging the patient. So we should see a symmetrical chest rise. So as long as the chest is rising and not the stomach rising, then we are in the lungs. We also listen for equal and lateral lung sounds, whatever that sound is. And then we shouldn't hear any sounds in the abdomen. Okay, so while we're bagging, we're listening, we're checking for placement. So there are many ways where we can verify placement while waiting for the chest x-ray. Again, the chest x-ray is important because we need to see where is the end of the tube because we can't see that. We need to see that it's exactly 2 centimeters above the carina. Meanwhile, again, one way to see if the tube is too far down is there will only be rise in the right side, in the right chest. Because of course you're bagging the patient, then of course it's if the tube is in the right bronchus, then only the right chest will rise. If it is that way, we will pull the ET tube. However, we usually wait for the x-ray because the x-ray report, in the x-ray report, the doctor will tell you exactly, okay, pull the tube by how many centimeters. Because the doctor, the radiologist knows the size, the length of the ET tube. So he will tell you how far to pull it if it's too far down or if it's too far up. The doctor will also tell you, okay, push it down this, at the 24 or 22 centimeter mark. I'm talking about these markings here. All right. So he already knows, okay, where to put it, how much, by how much to push it in or how much to push it out. Consequently, once we have confirmation that, so the doctor said, okay, keep it at the 24 centimeter mark. All right, so this is what we document. So this is where it's either in the teeth or on the lip. What if tomorrow, while doing your assessments, you see it at the 22 centimeter mark? What happened to the tube?
It went
And was it
down.
cold
This is the
or
teeth right
mellow?
here. The teeth are right here. So now you see it tomorrow, it's 22, not 24. What happened to the tube?
No,
It came out.
it
Went
went
down
up.
further.
It was pulled out.
Yeah, pulled out.
Because this is the mouth right here. This is the teeth. So if you see it at 22, that means it was pulled up. However, what if it's the other way around? What if you see it at the 26 centimeter mark?
Then it went down.
It was pushed in. All right. So how does this happen? Well, it happens all the time. We do every 2 hour mouth care, so it may have moved that way, because during mouth care, of course, we have to loosen which brings me to the next. After we get confirmation by X-ray, and then we observe lung sound, chest rise, and tidal CO2 detection, of course, we have to secure the tube. We have commercial tube holders. They're preferred over tape. We used to use tape only because we didn't have the commercial tube holders, but the tape loosens because the patient starts to sweat, they drool, they get wet during bed bath, so it's impractical. The tape will loosen, and then the tube will also come loose. Therefore, we're using commercial tube holders now because they have Velcro, they're more secure. So during mouth care, of course, we loosen this thing, and we need to move the tube anyway from side to side, because it will cause pressure ulcer if it's left in the same place. So every 2 hours we do mouth care, we also move the tube, and then we have to um, um, readjust the tube holder the same every time. But as you can see by the description, the two main ways you can confirm placement is really the end tidal CO2 as well as the chest x-ray. So you need those two at least to know that your tube is in the right place. So far we have verified placement. We have established a seal on the airway. So we have inflated the cuff, and we have secured the tube. Okay, now we just need to um, keep it patent. So we will now do suctioning as needed only. Sedation is routine because it's uncomfortable. Imagine having a plastic airway down your throat. So we need to keep the patient relaxed, because as long as they are anxious, restless, then they will continue to increase oxygen demand. Not good for a patient with respiratory failure, ARDS, etc. So there will be a continuous infusion of either propofol, usually is used in order to keep the patient comfortable. The other infusion is also usually fentanyl, pain medication, because we assume the patient is in pain. So we also give them a continuous uh, opioid drip. So again, to summarize, our roles are to keep that endotracheal tube patent by suctioning as needed, monitoring for complications, including poor cuff inflation or maybe overinflation. Here is um, mouth care as well as suctioning to maintain patency, and to make sure tube placement is maintained, and then of course monitoring oxygenation. Since the patient is sedated, we can only do evaluation by lung sounds, vital signs, and of course arterial blood gases. It's our job. Don't worry, you don't have to do arterial sticks, because the doctor will put in an arterial line. So now you have a means of obtaining arterial blood without having to stick the patient. Now we share this role with the RT. Alright, is that understood? So you don't say, oh, that's not my job, that's the RT's job. Well, you only have one RT on the entire unit. Maybe you'll be lucky if you have two, even though the RT can only be in one patient's room at a time. So if you need something for your patient, you are perfectly capable of doing all these tasks that the respiratory therapist is doing. We constantly still do never assume the patient doesn't understand or doesn't hear you. They can hear you. Some of them do remember. One of my coworkers got in trouble because of a comment he made while we were turning a patient. So we were turning a patient, cleaning doo-doo, and then he made a comment. Well, as soon as we rolled the patient, because the patient was exposed, he said, "Oh, that's a lot of bush." And then the patient, once she was extubated, she remembered that moment. And so my friend got into trouble. He didn't lose his license, but he went on vacation, okay, for a couple weeks without pay. At least he didn't lose his license. So we maintain communication once the patient is off sedation, for instance, or if the patient is, because endotracheal intubation is only good for up to 14 days. Beyond that, the patient must receive a tracheostomy instead, because there are too many complications from the endotracheal tube beyond 14 days, so we have to switch to a trach. So when that happens, now the patient is able to come off sedation. They can now communicate using boards or gestures, for instance, or maybe Ouija board, whatever you can use as a means of communication. And they can also start eating rather than getting um, all the feeding via NG tube. All right, suctioning is always done to on an as needed basis. You do mouth care every 2 hours, and during those mouth care, we also assess the need for suctioning. Please do not misconstrue these statements here. It just says that you assess the need for suctioning every 1 to 2 hours. However, you always do suctioning only as needed, right? So suction only as needed because it's harmful. Look, the suctioning procedure causes hypoxemia and bronchospasm, and it may also, you already learned last semester, this can also cause dysrhythmias. So only suction as necessary. However, you determine the need for suctioning, meaning you assess if they require suctioning routinely. Mouth care, no limit. You can do mouth care as often as you want if you have time, but other than that, we do it every 2 hours. These are the indications for suctioning. So when you hear these or audible secretion, or you can see secretions, okay, visible secretions, obviously coming out of the endotracheal tube. So yeah, they need suctioning. Suctioning here is easy because we do inline suctioning instead of open suctioning. So there's no need to rinse the catheter. So you just turn off the alarm on the vent, put in the suction until the patient starts gagging, and then or you meet resistance, and then apply continuous suction as you slowly withdraw the catheter, still under 10 seconds. Some complications on the airway are unplanned excavation. Usually this happens if we run out of, let's say we're extremely busy, the pump has been beeping, we didn't get to it, we didn't know therefore that it was the pump beeping, that the sedative bag is already empty, so the patient now is awake. Patient's awake, they're confused, what's going on? So the first thing they'll grab is the tube, so they'll pull that tube out. Another is aspiration. Your cuff obviously was underinflated, or infection. Infection here could be oral, or worse, it would be pneumonia, or even sepsis. I just remember. Remember I said earlier that there's a third lumen. So this type of ET tube, this is the standard we have. This is about 7. This one is 6.5. This is a small tube. Usually adults have 7 or 9. This one is 6.5. Anyway, so there's 2 lumens here. One for the airway. Well, this is where air comes in and out. Then we have the one for the cuff connected to the pilot balloon. And then we have a third lumen branching out here, which means there will be...
Sorry. Out of here. Where's here? We don't see anything.
You see it now?
Yes. Thank you.
Alright, so you have the airway here, air coming in and out. This is the cuff lumen connected to the pilot balloon. There will be a third one here coming out, which you can attach to suction. That third lumen will have holes right here. So you'll have some holes on the surface of this area. Now that hole doesn't mean that there's a hole in the airway lumen. No, that's just another lumen wrapped around the tube, connected to that third, which is a suction actually. So remember this here. So I said there will be secretions here, correct?
Yes.
And you can't get to it because this is now the throat. Your yanker will only stop about right here around the tongue, where the tongue is. You can't go down further. So to reach this area, that means you'll have to shove a suction catheter down the patient's throat to get to it and suction all these secretions. Now, if we had that high-low evac tube, there will be holes here all around, and then that one you connect to a suction extension tubing, and it will suck all these secretions here for you. Very easy, very convenient. Why they don't use it on all, I have no idea.
Is that considered the closed suctioning that you mentioned? Or do we have to physically
Well,
get a...
that is different. The
Oh,
suction,
okay.
yeah, the suction we have, inline suctioning, is connected to the tube. So it's right
Okay.
here. So um, the circuit, the T tube, there will be a T tube attached here, like literally T. So each end will go to the circuit, one from the oxygen source, one from the vent. So in the center will be in the center of the T will be your inline suction. So the suction catheter goes in and you pull it out. So there pretty much will be 3. So this one right straight here will be your suction catheter, inline suction, and then the 2 T's of course is from the vent and the oxygen source.
Okay. Oh, that's the one that's wrapped, that kind of looks like it's wrapped in plastic. That's the one that you're talking about. That's
Yeah, that's
pretty...
an inline
Okay.
suction, meaning
Okay.
it stays sterile. No need to wear sterile gloves. You can suction
Okay.
anytime. Okay, it's quicker.
Got it.
All right, restraints are only done as a last resort. We don't like to, speaking as a nurse, I don't like to restrain my patient because it's actually a lot more work for you to do, because they make it hard to restrain somebody. You'll have to do a lot of assessments. You'll have to do it every 30 minutes. So on top of the things you need to do, you'll have to fill out this checklist on the restraints alone, which can take 5-10 minutes every hour, every 30 minutes actually. So it's not worth it. Hey, I don't like restraints. It's not worth my time. So I just make sure my bag of sedation is full. that it's running and I have my pain medication infusing, there shouldn't be any unplanned extubation. Okay, and then be careful when you're turning the patient. Don't be a hero. Always ask for help because somebody needs to hold that tube while we're turning, because otherwise it will pull. And now you'll have to confirm placement, which you have to do anyway. But you can save yourself a lot of time if you um, ask for help. In the event of extubation, unplanned extubation, of course, you have no airway, so do your best. Attach a mask to the bag valve. Bag the patient manually while don't leave the patient. So grab the bag, just yell for help. Say help, my extubation. So bag the patient until somebody arrives. Then doctor will make a decision. Do we need to reintubate, or maybe they're doing good? They'll probably ask for an ABG, see how's the patient doing. Maybe they can try um, just oxygen. If not, then they'll be reintubated. We know this already. Okay. Okay, this is the subglottal suction I mentioned earlier. Like I said, I don't know why they don't use this type of tube, because it's really convenient. Plus it's best for the patient. That way you have subglottal suctioning all the time, so that in the event that you have a cuff leak, the patient won't have aspiration. It's really better, besides the convenience. As mentioned earlier, we switched to a trach if the patient continues to need ventilation beyond 2 weeks. There's only one disadvantage. If you read this, as I already discussed earlier, the patient can now get out of bed, you can put them in a chair, they can eat, they can communicate, they can be off sedation, probably off pain medication also, so they get better. They can exercise their legs, so therefore no DVTs. um, yeah, so it's so much better. There's only one disadvantage. It's just the communication, but that's not even um, a problem, because we have the patient can now write, use a Ouija board. So I mean, it's not even a disadvantage in my opinion. I don't have questions on the intubation procedure. I just described it earlier. Your questions will begin here under management, because we already described here for the um, verifying tube placement, the X-ray and tidal CO2 detector, etc. And we need the ET tube to be confirmed by X-ray that it's 2 centimeters above the carina. We did all that. So this is now the testable part, because you are now in charge of managing the airway and the ventilator. So routinely do your vital signs, lung sounds, verifying tube placement, ensuring proper cuff inflation, um, maintaining a patent airway by suctioning, securing the tube, etc.
Vent study, please.
Yes, later, baby.
Map.
Yes, later. Thank you.
Vent study, please.
Alright, and then about lung sounds. Make sure these are again indicators of um, possible suctioning.
Professor,
Yes.
quick question. Just looking at the table under action, last part, what does they mean by daily sedation vacations?
That's a routine. Um, it's to determine readiness for weaning, because we can't do assessment for whether or not the patient is ready to wean later, because it has to be done every day. Do we still need the patient to be on a ventilator? Just like when you have a central line or a Foley, when you ask yourself, is this necessary? So daily sedation is because you have to do breathing trials every day. Usually the day shift does that. So they'll turn off the um, the propofol for a few minutes, and then let's say usually 30 minutes up to an hour. And then if the patient comes to, and then we do breathing trials to see, because the longer this patient is on a vent, the harder it is to extubate them, meaning the harder it is to wean them off. So there has to be a trial every day. Is this necessary, or can the patient do without it? That's
Okay.
the purpose.
Got it.
Thank you for asking. Okay, so a trach. Please read the suctioning procedure on your own. This one, inline suctioning. So the only thing different here is you don't have like the one we did in clinic. I mean, in skills lab, we had the kit, right? We poured saline and all that, and then we, you know, what is this? Put on sterile gloves and all that. Well, this is a inline suctioning, so most of that we don't do anymore. We just go straight to the suctioning. Don't forget to hyperoxygenate though. All right. So pretty much that's it. And I'd like to remind you that your textbooks, although not mentioned here, I don't know why, but most recent textbook editions with airway suctioning, artificial airway suctioning, only artificial airway suctioning. The method is now continuous. You apply continuous suction as you withdraw the catheter. We learned ever since it was intermittent, right? But most textbooks now, latest editions say continuous. Now it's only for an artificial airway. So if you're still doing a open suctioning, nasotracheal or oral, without an artificial airway, um, you still do intermittent. So this one now inline, as long as it's an artificial airway, whether an endotracheal tube or a tracheostomy tube, continuous suction. Still under 10 to 20 seconds. Okay, so this is now the structure. This is your ET tube, and this is your tracheostomy tube. What was I gonna say? All right, so let's say this one pops out. So as you can see, the only thing holding this thing would be the ties that would be wrapped around the neck. So this is your faceplate here, and of course this cuff won't do anything. All the cuff is doing is preventing secretions from going into the lungs. So therefore, the only thing securing this around the neck are the ties, whether it's the twill or the Velcro straps, whichever one. The As far as the tracheostomy care is, there's a care here, table 7.6. I mean, you've done this in skills lab. I just want to emphasize that in this table, they have two persons doing the change, especially with the part where you change the ties. They have a two-person technique here, right here. The tracheostomy tube holder should be changed with two caregivers. This is the best practice. However, if you're alone, then do not forget that you need to tie and secure the new Velcro or twill first before you remove the old one. If you have a second person, then that's good. You can take off the old ties while the second person holds the faceplate um, for you in place, so that if the patient coughs, it won't pop out of the out of the incision. Now, If you don't have one and then this thing pops out, now it's close to impossible to put it in. That's why we need to have a spare ET tube at the bedside with an obturator. That spare is usually one size smaller, so if you use a 7, then your replacement should be a 6. There has to be an obturator, because here the incision looks open, but remember there's still tissues over this. So we have, right after the trachea, you have muscle, then you have fascia over that muscle, we have subcutaneous tissue over that fascia, we have the hypodermis, after that we have the dermis, and then the epidermis. So there you have several tissue layers before we get to the tracheal opening. So that means, and those layers do not stay put, they slide against each other. So after the doctor made several incisions, first incision to open the skin, a second incision to get to the muscle, and then a third incision to get to the trachea. So there are several layers there, and it's only one incision. It's not like the doctor carved out tissues to keep it open. He just made one single incision with retractors. Now imagine, so if the tube pops out, the tract created by that incision over several tissue layers, they don't stay open. They will start to close, and you will have a difficult time inserting a tube shaped like this, wherein the end is um, not rounded. I mean, it's shaped like a circle, but then the edges are sharp. It'll be difficult to screw that into through the incision. So that's why you need this, which is a rounded tip. So you put this inside this or inside this. That way the end is rounded. You can now insert that through the tissue layers, through the incision, and hopefully you'll reach the trachea. After that though, this is a solid plastic. You have to remove that after you have inserted the airway. Okay, don't forget to take this out, because of course the patient can't breathe. All right, just in the event that you screw this part here and your patient ends up in trouble, all right, or if you panic or can't find the extra airway, the patient screwed, you can't bag this patient, because where are you gonna bag it to? There's no you don't have an airway. We already,
So
let's
what do you do?
hello,
So what do
what?
you do if what do you do if it comes out?
Well, prevent it in the first place.
Well, yeah,
You-
but
you-
what do you do then? Because
But
patients could accidentally pull it out. Doesn't mean it's your fault. It could also be the patient's fault. You still gotta save them. So what do you do then?
yeah, that's what you actually do. That's why you have an extra one with an obturator. That's the only thing you can do. The example I'm giving you is, let's say this patient is unconscious, okay, and the extubation is your fault. And usually at that point, this is only 1 to 2 days after it was inserted, so it'll be extremely difficult to put it back in. Meaning, I'm just saying, if you don't have a spare one, you're in trouble, because you're gonna have to yell, and then in a panic, people might miss. Okay, where is that again? I can't find it. Or maybe you don't have one on the floor. That's why you didn't have an extra one at the bedside.
Oh, okay.
All right, this is for suctioning. Of course, the patients on the vent are also on a cardiac monitor. So if you have vital signs changes like this, especially saturation um, drops, then you stop the suctioning procedure. Um, I mean, it will decrease um, naturally, but if the heart rate is so low or the oxygen saturation is so low, then of course you have to stop. Again, minor drops is okay. It's expected. It does cause hypoxemia. Okay, I think that's it. yeah, you don't have to read the rest of these. We will discuss pneumothorax under chest trauma, which is probably later today in class. Okay, let's go back to ventilation now. Any question on airway management?
No.
Okay, let's go to mechanical ventilation. So we have an airway. We attach the patient to a mechanical ventilation. Let's talk about settings. Let's just go down the list.
Are we back to chapter 27?
Yeah, page 505.
Thank you.
All right, so I won't test you on the type of the ventilator because there are several. We have pressure cycle, time cycle, ventilators, etc. So regardless of the type, all of them though are capable of the common modes, and there are the same settings whichever type of ventilator you have. For particularly your ARDS patient, this is the mode that we will use. Airway pressure release ventilation, but this is not discussed in your textbook, so I cannot test it. Anyway, the description is it will be high frequency oscillating ventilation to deliver. You know what? Let's forget about that because it's going to be useless. Let's go now to where is my modes? My mistake. Um, it's page.
Is it back in chapter 7? The types of mechanical ventilation? Or no?
Yeah, back to chapter 7 because in 27 it only describes mechanical ventilation briefly, and then it went on to the management of a ventilator, but it doesn't talk about the types. But the complications are also listed here. All right, mechanical ventilation. Humans are negative pressure ventilators, meaning how we breathe is made possible by our diaphragm. So the diaphragm contracts down, air is passed, air is sucked in passively because the atmospheric pressure is high. So we're like a vacuum. Breathing, therefore, is effortless, and the same thing as exhalation. Exhalation, the diaphragm simply relaxes, therefore pushes back up against the lungs, and then air is exhaled passively. So totally effortless. We try to mimic that by making negative pressure ventilators. What we came up with is a large cylinder, the size of a water heater. So what we do is put the patient in that cylinder with only the head sticking out, and then we create a vacuum inside, sucking air into the patient's lung. Very impractical, very inconvenient, because that means if we have to do anything to the patient, let's say clean doo-doo, um, assess lung sounds, and do whatever, we'll have to take them out of that cylinder. So impractical. Even they did some modern ones with which is not made of steel. We have like a body bag with still the patient's head sticking out. It's still very inconvenient. So we did away. You'll see these though in museums, or maybe a few old houses may have them because of the polio epidemic. Because polio also affected the lung, not only the legs. So those people who had pulmonary polio needed ventilators. So that's what they had at that time. Then we have positive pressure ventilation, which is more practical, which is easier. And of course, we need an airway to do this. So now it's positive pressure, so we're now blowing air into the patient's lung. Please read the description on your own. Pretty much the ventilator will deliver a breath. It will not suck out air during exhalation. Exhalation remains passive. All right. So let's go to settings first, and then we go to the modes. So we are doing artificial ventilation. So instead of the patient breathing on their own, we're using a machine to deliver the breath to the patient. So you have to tell the machine what to do. So one setting on the vent is the FiO2 because we're giving oxygen with it. It starts at 21%, close to normal, close to room air, but not entirely. You can still hear me, right?
Yes.
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 Who's absent? I'm missing somebody. Anyway, so it starts at 21. Usual setting is around 24, 28 maybe. But we can do, just know that we can do with 21. Doesn't have to be higher than room air. Next is the rate. You have to tell the vent, okay, how many times do you want me to deliver this breath? So in most vents, and most modes, sorry, particularly the first mode that you use for most patients is between 8 to 12. The reason for this is patients, no matter how bad they are, they're still breathing. So we don't really need to put the rate at a high setting because the patient, remember, adds to this rate. They can breathe on their own as well in between ventilator delivered breaths. So that's why the first mode will be put, the usual setting is around 12. Okay, you can do 8 to 12. You can also do lower depending on where you're at. Let's say you're at the weaning stage, so we drop the ventilator delivered breaths. But we'll go through those. But just know that the usual setting is around 8 to 12. So you tell the ventilator how often to give a breath. On the screen, this will be either rate, it will say literally say rate, or maybe it will say F for frequency. Tidal volume. The symbol is capital, meaning big letter V, and the T is really small and put down here. So it's the symbol is a V, and then the T will be right down here. So that's tidal volume. Most hospitals use the weight as the basis. So it's 6 to 10 or sometimes 6 to 8, depending on the facility. Some facilities even use the height. which I think is better because the patient's lung size really is determined by the height, not the weight. Do you agree? Imagine somebody who is 4'8" but weighing say 500 pounds versus a 6'4" patient but only weighs 160. Which one would have a bigger lung?
The 6 foot one?
The
Yeah,
taller
the tall
person.
person, right? So for me, it should really be the height. But what do I know? Most people, most hospitals use the weight, usually around 8 mils per kg. Um, so that would bring us around 400 milliliters as the commonly used tidal volume. The tidal volume will be based on two things. One is the patient's lung compliance, and also um, the what is this? The compliance is the flexibility and the ability of the lung to recoil. Okay, here. Oh, it's still here from yesterday. So C here is compliance. Compliance is how do I describe it?
The elasticity of the lung.
Yeah, okay. Very good. So a normal lung would be elastic. It's air-filled and can recoil. So that means if it's dry, meaning there's nothing wet, no pneumonia, no ARDS. So if it's air-filled, it will of course expand as the millions of alveoli fill with air, and then during exhalation, it can also recoil and then able to push out air outside. Okay, I know. Let's try this. So let's say a sponge. So if I have a dishwashing sponge. So if I have a sponge, can it, and it's a brand new sponge. If I fill it with water and then I squeeze it, will it recoil? Let's say as the water squeezed out, will it regain its normal shape?
Sponge, yes.
Yeah, sponge. Yeah, sponge can do that, right? Now imagine if that same sponge, if I dip it in glue. So let's say I have a basin full of glue. I put glue in the sponge. I let it absorb glue, and then I put that sponge out in the sun for 5 hours. Will that still be flexible and soft?
No.
No more.
No.
Now it's very hard and stiff, right? So that is compliance now. So the normal lung has a high compliance. A bad lung will be very stiff and therefore very hard to ventilate. So this is now compliance. So the doctor makes a decision on how much tidal volume and how much pressure to deliver the tidal volume at, depending on compliance. So the formula is change in compliance equals change in pressure over change in volume. So if you have a very highly compliant lung, how much pressure do you need in order to, let me clear this. So if you have a very compliant lung, how much pressure do you need for the vent to oxygenate that lung? How much
Not
pressure do you need to deliver a breath?
minimum,
High or low?
low.
Low.
You'll need less pressure in order to blow air into that. And how much volume do you think it can accommodate?
High.
Higher volume. So this is the principle. So the doctor determines the compliance of the lung based on the diagnosis or based on X-ray. So based on his training, you see compliance is low, compliance is high. He makes a decision. So conversely, inversely, so if you have a very poorly compliant lung, how much pressure do you need in order to ventilate that very non-compliant lung?
A lot of pressure.
Higher pressure. How much volume do you think it can take?
Less.
Less
Less.
volume.
Less volume. So this is the principle. So when you take care of a patient on a ventilator, this is what we're doing. So the mode and the settings depend on the patient's condition. It depends on the lung compliance, because you cannot just put one set of tidal volume, rate, and pressure for all patients. You have to individualize it depending on their condition and depending on their needs. So that's tidal volume. Now, as far as PEEP goes, this is a setting also on the vent. Your textbook only talks about three settings, but that should be good. So what is PEEP?
P is pressure.
Positive and expiratory pressure.
Very good, children. Okay, so let's say this is a visual representation of our breath. So let's see, this is Barbara's lung. So we're measuring her breathing. We are negative pressure ventilators. So if this line is 0, when she takes a breath, as her diaphragm contracts, pressure goes down first. So that's the right before she takes a breath, and then you go. She takes a breath, and then she exhales, pressure goes to 0. Next breath, let's say 5 seconds later, the same thing, right? And so on, because she is a negative pressure ventilator. So this one here is called the peak inspiratory pressure. This is the highest pressure at the peak of inhalation. Now let's look at the ventilator. Ventilator is a positive pressure ventilator. So the breath always starts above 0. So the vent goes, psh, gives a breath, and as during exhalation though, at the end of exhalation, unlike here where when we go to 0, this one will not, because you have PEEP. So PEEP can be anywhere between 3, 5, 10, 15, 20 centimeters of water. Now, what this means is there's a certain pressure that the ventilator continues to deliver. Pressure, not a breath. It delivers a pressure to keep the alveoli from collapsing, or to keep the alveoli from going to 0 pressure. Meaning the whole time, the lungs will stay sort of inflated, okay, a little bit. It doesn't allow the lung to completely have no pressure. So even at the end of exhalation, there is some pressure being blown into the patient's airway, into the patient's lung. Understand, PEEP? So PEEP is therefore used for 2 things. One is to prevent alveolar collapse. Second is to prevent the need for higher FiO2. The principle is, instead of increasing your oxygen concentration, why not prolong the delivery? Why not let it hang around there longer? That way you have an extended gas exchange and therefore no lung collapse. Therefore, having PEEP there eliminates the need for higher FiO2. At least that is the intention. So that is positive and expiratory pressure. Now imagine the drawing I showed you earlier. If the pressure though is higher, if the PEEP is set at beyond 15 is already the maximum safe. Sometimes the doctor will increase it to 20 for short periods. So I emphasize only for short periods, because imagine if you have a higher PEEP, remember the heart is squeezed every time you breathe. And the only time the heart is able to regain or recover full expansion, therefore increase um, what is this? Increase venous return, is to re-expand at the end of exhalation. So therefore, if you're what was I saying? Oh, if your PEEP is so
Venous
high,
return.
yeah, so if your PEEP is so high, that means it doesn't allow the heart to fully expand. The heart will be squeezed extra long. Remember, the heart is already squeezed at the peak inspiratory pressure, at the height of inhalation, because both lungs will inflate and then squeezing the heart. So it's already having decreased venous return, therefore decreased cardiac output at that particular moment for maybe 0.1 seconds maybe. But now with PEEP, with a high PEEP in particular, that could potentially drop your cardiac output. So high PEEP should only be used for a very short time. It's usually dialed higher if we have a very non-compliant lung. So that's when the doctor increases the PEEP. So again, instead of increasing FiO2, we will just increase the PEEP, because increasing FiO2 for long periods of time will of course cause oxygen toxicity. Let's go to the modes now. Let's begin with the controlled mode. Controlled mode is a volume mode. This is used only on the OR. Before I proceed, the mode is chosen based on the work of breathing. Work of breathing meaning who does most of the ventilatory work? You want the patient to do most, or do you want the ventilator to do most? Or basically as simple as how much work do you want the vent to do? How much work do you want the patient to do? In controlled mode, the ventilator does 100% of the work. As I described earlier, in the OR, a patient receiving general anesthesia, of course, this patient is paralyzed because we can't have them moving while we're cutting and stretching, tissues. Let's say this patient is able to do that, then let's say the patient sneezes, and this is just as the doctor is trying to anastomose um, a vessel into a coronary artery, right, doing a bypass graft, and then the patient moves. Okay, so it can be devastating. So the patient is paralyzed, so therefore even that will include the diaphragm. So therefore you have to put them on a controlled mode, that way they continue to breathe. Okay, the ventilator does all the work. So here the patient has no control over breathing at all. So the vent is in charge. The vent is in charge, decides when you get a breath, how many times a minute you get a breath. So you attempt to take a breath in between those ventilator delivered breaths, you'll not get any. Okay, so if the patient attempts a breath, the breath will not be supported by the vent. And remember, you have an airway. It'll be extremely difficult, even impossible to take a breath. All right. So controlled mode is only done or used in the OR. You'll not see it anywhere on the floor because it's extremely uncomfortable. Assist control is the most commonly used mode. So chances are, if you see a code somewhere, a patient is intubated in whatever setting, chances are they'll be put on assist control, unless of course the diagnosis is ARDS, then it's a different mode. But most people, for whatever reason, respiratory failure, pneumonia, um, severe opioid overdose, for instance, they will be put on assist control because these patients aren't like not breathing at all. They're breathing, but very weak or very low respiratory rate. So we just need to support that ventilation. So we put them on assist control. Assist control is a volume mode. All volume modes have a preset rate. They have a preset volume. Here, respiratory rate and volume is preset. That means there's a minimum number of breaths being delivered by the vent, and then there's a minimum tidal volume that is delivered with each breath. So let's say the rate is 12 and the tidal volume is 400. So therefore, if it's 12, every how many seconds will the patient receive a breath per minute? $60 divided by 12.
5.
Okay, so every 5 seconds on the dot, this patient will receive a breath from the ventilator. If the patient doesn't breathe, no problem. We have a preset rate. We have a preset tidal volume. So no breath from the patient, fine. The ventilator delivers a breath regardless of what the patient does. If the patient breathes, which most of them do, the ventilator will allow the patient to breathe. However, the patient has no control over the tidal volume because the ventilator will give the patient the preset tidal volume. So the only thing here that the patient can control is the rate, because the patient can increase the rate. They can never change the tidal volume. Does that make sense? Let's put it this way.
Yes.
The patient can breathe faster than the set rate. They can never breathe less because the minimum is preset. Regardless if the patient breathes or not, they will get 12 breaths per minute if that is the setting. If they breathe on their own, they will be allowed to breathe as many as they want. However, they cannot control the tidal volume. If the vent senses that they're trying to breathe because the pressure goes negative, the ventilator will deliver the patient the preset volume, the preset tidal volume to the patient. Get it?
I get the rate, but I don't get the tidal volume.
Okay, because it's the tidal volume is preset. This is a volume mode. Remember, there are two things preset in any volume mode. So we started with control mode. This is a volume mode. So therefore, it will have a preset rate, preset volume. All right. This is another volume mode. There's a preset rate, there's a preset tidal volume. However, in this mode, although the patient can breathe faster than the preset rate, meaning they can add to it, therefore they will increase the 12 to potentially 18 or maybe 24. They can take 12 breaths on their own. However, one thing they cannot control is the volume. The tidal volume is going to be delivered by the ventilator every time they take a spontaneous breath. Is that understood? So the only thing the patient can control here is the rate. They can add to it, they can increase the rate. However, they can never change the tidal volume because every time they attempt a breath, the ventilator is programmed, okay, you're trying to breathe, here you go. The ventilator will give them the preset tidal volume. So this is only good for a really bad patient. If a patient gets better, this is extremely uncomfortable. Plus, this may potentially cause respiratory alkalosis because the patient, remember, adds to the rate. So if this patient gets better, that means their respiratory rate will naturally increase. Their spontaneous breaths will naturally increase, adding to the preset rate on the vent. Therefore, this could potentially lead to 24, 36, and there's no limit to the number of breaths here. All right?
Yes.
Because it will result in hyperventilation eventually. So at that point, as you're doing your routine ABG, if you start seeing respiratory alkalosis, that means this patient is breathing faster. They're getting better. So you need to report that to the physician, then maybe we can advance them to a different mode. Obviously, this mode is no longer appropriate for this patient. Any question on assist control?
Professor, wouldn't you see the rate going up on the ventilator instead of waiting for like the ABG?
Yeah, you'll also see it. But
Okay.
how do you support it though? The doctor will ask you for an ABG.
Okay.
Okay. Intermittent mandatory is similar, so I'll skip that one. So we'll test control, assist control, and then this one. So this is the next step. If the patient is now getting better, we can switch them to SIMV. Usually the steps are assist control because that's where most patients are put on, and then if they get better, then we can switch them to SIMV. So SIMV is synchronized intermittent mandatory. It's still the other name for assist control, by the way, is CMV, meaning controlled mandatory no, sorry, not controlled. Continuous mandatory ventilation. Continuous because there's a preset, there's a preset rate, preset tidal volume. So it's continuous mandatory. However, the patient is allowed to breathe. So the name is also called assist control. In SIMV, the patient here obviously is better. So the preset rate in SIMV, this is also another volume mode, by the way. So as with any volume mode, what is always preset?
Tidal volume.
There's a preset tidal volume and there's a preset
Rate.
rate. Okay. So here, this is another volume mode. So the patient gets a minimum number of breaths. They also get a certain tidal volume with each breath. However, the difference here is, let's start here. Let's start here. So this can be a main vent mode, or this can also be a weaning mode. All right, so this is the benefit of this thing. This mode can be a main vent mode, meaning the patient's getting better, but obviously not ready to go without the vent yet. Or it can also be used strictly as a weaning mode. So this is how it works. If a patient doesn't take a breath, no problem. The ventilator is this is a volume mode, so therefore the vent delivers a minimum number of breaths with a minimum tidal volume, just like assist control. The difference here is if the patient takes a breath, the vent allows them to determine their own tidal volume and even the rate. Again, it's a volume mode. There's a preset tidal volume, there's a preset rate. However, if the patient takes a spontaneous breath, the patient determines their own tidal volume. The vent will not give them a tidal volume whenever it's a spontaneous breath. Any question on that? Because in assist control, when the patient wanted to take a spontaneous breath, spontaneous, their own breath, the vent gave them the tidal volume, the preset tidal volume. In SimV, if a patient takes a spontaneous breath, the vent will not deliver the tidal volume. The vent allows them to breathe at their own rate, at their own tidal volume. However, if they don't breathe, of course, the vent will give the preset volume at the preset rate. So does this sound comfortable?
Yeah, that sounds better.
Right, so this is now only though for better patients. If the patient is still bad, they'll stick with the assist control because that's the best mode for those patients. A better patient who's now breathing more is not appropriate to be on assist control anymore. They need to be on this one. Because remember, the vent is a computer. The vent does analyze and establish a pattern for your respiratory, the patient's respiratory pattern. No, it's a computer, so it analyzes, okay, how, what's this patient's usual um, pattern. Okay, so it establishes, oh, the patient's breathing 12 or sometimes 14, and they're taking this much tidal volume. Okay, so it analyzes the pattern and synchronizes with it. So if the patient, let's say, misses a breath here and there, it will deliver the preset volume at the preset rate. So it's more comfortable, it's more synchronized, unlike something I didn't mention here in assist control. So let's say it's just the preset rate is 12, right? And so the patient therefore gets a breath every 5 seconds. So as long as the patient breathes, let's say 3 seconds later after the vent delivered the breath, that's fine because we only need 1 second to breathe, right? So that's fine. If they breathe at 3 seconds later, they'll get a breath, and then by the time 4.5 seconds is done, you're done with your exhalation, and then at the 5th second you get another breath. The problem there is potentially, what if the patient breathes around 4 seconds later after the ventilator gave the breath? So let's say the patient initiates a breath 4 seconds later. So that means the patient gets the preset tidal volume for the spontaneous breath at 4 seconds. Will they have enough time to exhale before it's time for the preset ventilator breath? Do they have enough time to exhale?
No.
No time. So halfway, probably when they're attempting to exhale, it's already time for the next breath. So they'll get another breath on top of the breath that they just took. So that means there could be breath stacking here, extremely uncomfortable. Because imagine you're trying to exhale, right? Because your lungs are full. But then it's already time. Too bad. It's already time for the next breath. So you get, imagine this. You go breathe, right? Take a deep breath. And then instead of exhaling, you're getting another breath. So that's extremely uncomfortable. So there could be breath stacking that could occur in assist control. It happens occasionally, and you'll see the patient, twitch, get restless because of that. Because I mean, who wouldn't get it? It's like you're drowning with air, right? You're getting too many breaths, get too much tidal volume. That doesn't happen in SIMV because again, the SIMV synchronizes with your respiratory pattern. So if it's time for the next breath, but then it analyzes, oh, he just took one a couple seconds ago, so I won't give it now. So it's the SIMV is smarter. It's a smarter robot, whereas assist control is a dumb robot. It's just doing, it's literally a robot. It's not thinking. Yes, question?
So for the assist control is basically we have the preset volume and tidal volume for the rate and the tidal volume. So then for the SIMV, it's like a
Same.
smart computer that detects and gives it, or do we set the preset volume and tidal
Now,
first?
doctor gives you the orders. So this is still a mode, don't get me wrong. SIMV and assist control are both volume modes. So they have a preset rate, they have a preset tidal volume. They're the same. The difference is when the patient takes a spontaneous breath. In assist control, the vent gives them the tidal volume, the preset tidal volume. In SIMV, it doesn't. It allows the patient to take their own tidal volume. If the patient wants less than the preset tidal volume, they can do that. If they want more than the preset tidal volume, the patient can do that. As long as it's a spontaneous breath. If the patient doesn't breathe, then the vent will deliver the preset tidal volume. Does that make
Would the,
sense?
yes, and would the preset volume and rate be lower on the SIMV?
Yes, naturally, because that's why we put them here is because they're breathing faster now. So
Okay.
unlike here in assist control, wherein typically the minimum preset rate here is around 12, in SIMV we can drop it to 8 all the way to 1. In fact, when we are using this as a weaning mode, the preset rate is 1. They only get 1 breath per minute because the patient is already breathing a lot. Does that make sense?
Yes.
Okay. We won't do air pressure release. This is the vent used for, it's pretty much it's not commonly used, so that's why I'm not testing it. It's part of a weaning mode. This one is commonly used though. Pressure support is a pressure mode. Uh, Volume mode has a preset tidal volume, preset rate, right? Pressure modes don't have a preset rate, don't have a preset tidal volume. Therefore, does a pressure support ventilator mode give any breaths at all? If there's no preset mode, I mean, there's no preset rate, no preset tidal volume, does it give a breath?
No.
It's
No.
not.
No.
No,
No.
not at all. So this is only given or used in a patient who is being weaned. There's no way that a bad patient will be put on pressure support. They'll die on this mode because this pressure support does not give any breath at all. It's a pressure mode. It only provides pressure support. Literally, that's what it's doing what its name implies. So it only gives pressure support. So these are patients who are being weaned, but obviously they're not ready for extubation just yet, but they're getting there. So we're just giving them a little push. So think of it as in the gym. So there's a spotter on the gym, correct? In case you get in trouble, they'll help you on the bench press, okay? So that you don't kill yourself. So they'll just give you a little bit of support, okay? A little help with breathing. So that's all it gives. It gives them a pressure support during inhalation and exhalation, kind of like a CPAP, right? But it's a ventilator though. It gives higher pressure than a CPAP, and that's all it is. Complications now. So this was mentioned a little bit earlier under airway. So this is the hypotension. Of course, this is from the PEEP. Especially if you have high PEEP, then that will lead to hypotension. Infection is the pneumonia. Barotrauma, I described it earlier with the breath stacking and assist control, meaning you have so much pressure now stacked on top of each other. Aspiration, this is an airway, the artificial airway problem, meaning your cuff is underinflated or you did not suction the subglottal area. And then finally, the most serious is ventilator-associated pneumonia. Let's go to the alarms and then we'll talk about each complication. So your book only mentions 2. We have table 7.8, we have high pressure and low pressure alarm. long story short, the difference between the two is in the resistance. Here, if you look at each one, all of these 1, 2, 3, 4, 5, 6 causes listed here, these cause increased resistance between the ventilator and the patient. Because remember, do we have a picture here? Here. So remember, between the vent and the patient, there's a considerable distance here. So the circuit usually are around 6, I think they're 6 feet long, maybe 8. So there's a distance here between the patient and the vent. So the vent has to exert pressure in order to deliver the breath. Now, if there's any increased resistance listed down here, which is, let's say the patient bites the tube. Okay, the patient is awake partially, they bite the tube, or let's say they have secretions. Here, if you look at here, there's a humidifier here. Of course, and this is a large volume of air we're talking about, so there will be condensation in this loop here. Okay, so you have dependent loops, so there could be condensation here, condensation here. If that condensation increases, of course that will obstruct the hose, so now the circuit, so that would trigger a high pressure alarm. Another is, let's say this patient from barotrauma develops a pneumothorax. Now there's a hole in the lung, so therefore that will increase pressure, positive pressure in the lung, making it harder for the vent to deliver the breath. High pressure alarm is triggered, and so on. So question on the exam would be the cause. It could be, which of the following will trigger a high pressure alarm, or it could be the intervention. So what do you do? Which of these actions will the patient do if a high pressure alarm is triggered? Okay, so either this column or this column. Same thing for the low pressure. In low pressure alarm, this is the opposite. This one obviously no resistance because there's a leak either in the cuff or in the vent circuit, or the patient stopped breathing, so there's no resistance, or the patient is extubated. The airway is no longer in the patient, it's on the bed, so therefore there's no resistance. And these are your actions. Again, the questions would either be this or that. And all right, here's a warning. Things go wrong with the vent and you try your best to fix it, you can't fix it. As a result, the vent the whole time is not giving a breath because there's an alarm that it's asking you to fix, but then you cannot figure it out. You tried your best, it won't work. So best thing to do is disconnect the patient from the ventilator. Here, disconnect the patient, take the circuit off, and then manually ventilate the patient until help comes, or they can fix the problem, or if they can replace your vent. For
So
the
you're on a
other,
time limit.
sorry,
You're on a time limit of like finding the problem before you have to call. How long would that be?
a few seconds, probably 30, because remember the whole time the patient's not getting any breaths from the vent.
Yeah, 30
So
seconds.
better, yeah, so it's better take them off that vent, just remove the circuit, the hose, just remove that and connect your bag valve mask.
And while that happens, you will deliver oxygen manually, correct? With the ambu bag?
Yeah, just the ambu bag.
Okay, thank you.
All right, for the others, please read them on your own. I won't read it. Just read the description. The question would either be the cause or the action. Okay, what's causing this? Because meaning if you know the cause, then you can prevent it. Intervention, of course, what do you do if you see this complication? So do that for hypotension, infection, barotrauma, aspiration. For ventilator-associated pneumonia, we have a box here. This is VAP. This is a bundle. Now, this is not complete. The complete one is in chapter 27. Let me see if I can get there. 99. No.
506.
506. Okay, right here. But this is missing one. See, that's why I don't like this table, because it's all over the place. Anyway, your VAP bundle are the following. You do mouth care every 2 hours. You brush your teeth every 12. This is part of the Q Care kits. I mean, it's a no-brainer. It's hanging at the bedside. Never keep them lower than 30 degrees. 45 is not really encouraged either because of pressure ulcer, no shear injuries, because these patients obviously are bedbound because you're sedating them. So 30 is perfect. This is the subglottal suctioning. So not only suction as needed, but also suction the subglottal area. And one of the things missing here, which is in the other one, let me go back there. 99 is the pH. So the gastric pH must be kept high. So we add the, where's the PPI? Right here. So we add the peptic ulcer prophylaxis, because this is H2 receptor blocker or PPI. This will keep your um, pH higher. That way, if the patient does aspirate, at least we won't have acute lung injury. So this is part of the pneumonia bundle. DVT and this one, of course. Now the frequency, I know it says daily, but this is done every 2 hours. All right, mouth care every 2 hours, brush their teeth every 8. I know the thing said 12, but if you see the kit, there are 4 Q Care kits every 8 hours. That means you use one every 2 hours. The fourth one has a toothbrush. That means you have to use the toothbrush once every 8 hours. That means, therefore, the brushing teeth should say 8 hours, not 12. And that's it. So you do that, your patient won't have pneumonia, therefore won't get septic, won't go into shock, and they'll live. Okay, and then they also even added here the sedation vacation. All right, any question on mechanical ventilation? I'm not testing it on weaning. We have no time. All right. So I'll
Okay.
see you in 9 minutes.